Welcome back to Audioboards. Today we're diving into inpatient hypertension management, specifically how we handle elevated blood pressure in hospitalized patients. And honestly, this is one of the most misunderstood areas in medicine. Because elevated blood pressure in the hospital is everywhere. Depending on the study, up to 72% of hospitalized patients have elevated blood pressure at some point during admission. But here's the key question.
Does every elevated BP need treatment?
And the answer is no, absolutely not. The American Heart Association recently released a major scientific statement trying to standardize how we approach inpatient hypertension, because unlike outpatient hypertension management, where we have tons of evidence and clear guidelines, inpatient BP management is actually driven by surprisingly limited data. That lack of evidence has created massive variation in practice. One clinician aggressively treats every systolic over 180, another ignores it unless there's organ damage, and hospitals everywhere are still using PRN IV antihypertensives that may actually harm patients. So today we're going to break down how the AHA recommends thinking about inpatient hypertension.
And honestly, I feel like this is something everyone sees constantly on the wards. Somebody's pressure hits 190 overnight, and suddenly everyone panics.
Exactly. And that panic is actually part of the problem. The AHA specifically recommends moving away from emotionally loaded terms like hypertensive urgency or hypertensive crisis because they push clinicians toward reflexive treatment instead of structured evaluation. Instead, they recommend objective classifications. So let's define the categories first. The most important category is the hypertensive emergency. That means BP greater than 180 over 110 to 120 plus evidence of new or worsening target organ damage. Not just a high number, you need actual organ injury. Examples include acute ischemic stroke, intracranial hemorrhage, myocardial infarction, acute heart failure with pulmonary edema, acute kidney injury, aortic dissection, hypertensive encephalopathy. That's the patient who truly needs rapid blood pressure reduction. Then there's the second category, asymptomatic markedly elevated inpatient BP. That's BP over 180 over 110 to 120 without target organ damage. And this is where overtreatment becomes extremely common. Finally, the third category is asymptomatic elevated inpatient BP, meaning pressures over 130 over 80 without organ injury. And honestly, most hospitalized patients fall into that last group.
So the number itself isn't the deciding factor, it's whether there's end organ damage.
Exactly. And before we even talk about treatment, we have to talk about blood pressure accuracy. Because inpatient BP measurements are often terrible. Think about how these readings happen in real life. Patient lying supine, wrong cuff size, patient in pain, patient anxious. Nurses waking them up at 3 a.m., sleep deprivation, active illness, cuff over clothing. All of these factors can falsely elevate readings. The AHA emphasizes standardized measurement techniques before initiating treatment cascades. For true hypertensive emergencies, arterial lines are preferred because cuff pressures may actually underestimate severe hypertension by as much as 50 over 30 millimeters of mercury. Continuous arterial monitoring also allows safe titration of IV medications.
That's wild. So sometimes the cuff isn't overestimating, it's actually underestimating.
Correct, especially in critically ill patients with severe vasoconstriction or shock states. Now, the AHA introduces a really useful framework called the AIM approach: assess, identify, modify. This is the foundation for inpatient hypertension management. First, assess. Confirm the BP is real and evaluate for target organ damage. The statement uses the acronym BARKH: brain, arteries, retina, kidney, heart. So when you see severe hypertension, ask, is there neurologic dysfunction, chest pain, pulmonary edema, AKI, aortic dissection, retinal hemorrhage, or papilledema? If none of that exists, you're probably not dealing with a hypertensive emergency. Second, identify. Look for reversible causes. This is huge because most inpatient hypertension is reactive. Common contributors include pain, anxiety, acute distress, volume overload, withdrawal syndromes, missed home antihypertensives, NSAIDs, corticosteroids, stimulants, And third, modify. Fix those underlying drivers before reflexively pushing antihypertensives. That's the core philosophy shift here.
So instead of treating the number immediately, you treat the context first.
Exactly. And this leads into one of the biggest conclusions from the statement. Treatment of asymptomatic elevated BP should be the exception, not the rule. That's incredibly important, because observational studies consistently show harm from aggressive inpatient treatment of asymptomatic hypertension, especially IV medications and PRN dosing. These studies associate aggressive treatment with acute kidney injury, myocardial injury, stroke, abrupt hypotension, higher mortality. And there's another issue people forget. PRN antihypertensives disrupt home medication regimens. A patient gets IV hydralazine at 2 a.m., their scheduled oral medications get held, blood pressure swings wildly, and suddenly you've created variability instead of stability.
And we've all seen that overnight treat systolic above 180 order set.
Exactly. The AHA is essentially telling clinicians to stop doing reflexive PRN treatment in asymptomatic patients. Now let's walk through actual management by category. Hypertensive emergency is patient with severe hypertension plus organ damage. These patients require immediate parenteral therapy, ICU level care, continuous monitoring, preferably arterial line blood pressure measurement. But even here, blood pressure lowering must be controlled. Overly rapid reduction can worsen ischemia by impairing autoregulation. Now let's go organ system by organ system. For neurologic emergencies, stroke or intracranial hemorrhage, the preferred agents are usually labetalol or nicardipine. Labetalol works through combined alpha-1 and non-selective beta blockade. It reduces vascular resistance and heart rate simultaneously. Advantages: rapid onset in 2 to 5 minutes. Minimal reflex tachycardia, can be bolused or infused, but avoid it in asthma, advanced AV block, severe bradycardia, decompensated heart failure. Nicardipine is a potent arterial vasodilator through calcium channel blockade. Advantages: smooth titratable BP control, cerebral and coronary vasodilation, easy infusion adjustment, but watch for reflex tachycardia, hypotension, worsening pulmonary edema in susceptible patients. Nicardipine feels like the ICU favorite lately. It really is because it's smooth and predictable. Now for cardiac emergencies, a CS or acute heart failure, several agents come into play. Nitroglycerin, nitroprusside, clevidipine, labetalol, esmolol. Nitroglycerin primarily venodilates at lower doses and arterial dilates at higher doses. That reduces preload and improves coronary perfusion. Great for pulmonary edema and ischemia. But avoid it with PDE5 inhibitors, right ventricular infarction. Nitroprusside is incredibly potent. It causes balanced arterial and venous vasodilation with near immediate onset. But it requires ICU monitoring because of cyanide toxicity risk, reflex tachycardia, increased intracranial pressure potential. Clevidipine is another ICU favorite, ultra short acting, very titratable, rapid on-off effect, but avoid it in soy or egg allergy, lipid metabolism disorders. Esmolol is especially useful when heart rate control matters, particularly in aortic dissection. It's a short-acting beta-1 blocker with onset in 1 to 2 minutes. And in aortic dissection, heart rate control is just as important as pressure reduction. Absolutely critical. For aortic dissection, beta blockade comes first, usually esmolol, before adding vasodilators like nitroprusside or nicardipine. Otherwise, reflex sympathetic activation can worsen shear stress. Now, for hypertensive emergencies involving the kidneys, acute kidney injury, nicardipine, clevidipine, or phenoldopam are commonly used. Phenoldopam is interesting because it's a dopamine 1 receptor agonist. It vasodilates while preserving renal perfusion. But watch for reflex tachycardia, hypotension, increased intraocular pressure. Across all hypertensive emergencies, medication choice depends on organ involved, desired speed of reduction, need for heart rate control, comorbid conditions, and again, avoid dropping BP too fast unless clinically necessary.
What about asymptomatic markedly elevated BP?
Now, this is the category that causes the most confusion. BP over 180 over 110 or 120, but no target organ damage. The AHA's message here is extremely clear. Pharmacologic treatment should be uncommon. First, confirm the BP is accurate. Then address pain, anxiety, sleep deprivation, volume overload, missed home meds, avoid IV antihypertensives, avoid PRN medications. Because rapid BP reduction beyond roughly 25 to 30% can impair autoregulation and trigger hypotension or ischemia. If medication adjustment is needed, oral therapy may be considered, especially in patients with persistently uncontrolled outpatient hypertension, but it should align with standard outpatient hypertension guidelines. So this isn't about fixing the number before discharge. Exactly. In fact, aggressive discharge intensification may worsen outcomes because inpatient BP often reflects temporary stress physiology rather than baseline chronic hypertension.
How about asymptomatic elevated BP?
This is the everyday inpatient patient, BP above 130 over 80 without organ injury. And for these patients, the emphasis is correct situational factors. Restart home medications if they were interrupted, treat pain, treat anxiety, improve sleep, address volume status, and importantly, avoid unnecessary medication escalation. Most inpatient BP elevations are transient physiologic stress responses.
So the hospital itself is basically a perfect setup for elevated blood pressure.
Exactly right. Pain, stress hormones, poor sleep, illness, procedures, interruptions. It's all hypertensinogenic, which is why the AHA strongly emphasizes transitions of care. And they actually use a second AIM framework for discharge planning. Arrange. Follow up within 2 weeks. Inform. Educate patients about BP control and lifestyle strategies. Monitor. Use validated home BP devices. And the best evidence supports continuing pre-admission regimens rather than intensifying therapy at discharge unless it's coordinated with outpatient primary care.
That continuity piece is huge.
It is, because long-term blood pressure control depends far more on outpatient follow-up and longitudinal care than aggressive inpatient correction. And the AHA also highlights major research gaps. We still need randomized trials defining optimal inpatient BP targets, which patients benefit from treatment, short-term versus long-term risks, appropriate thresholds for intervention. There's also a strong emphasis on health equity because socioeconomic barriers and limited access to outpatient care dramatically affect post-discharge control. So to summarize the big clinical takeaway, not every high blood pressure in the hospital is dangerous. Hypertensive emergency is defined by organ damage, not the number alone. For asymptomatic inpatient hypertension, verify the measurement. Look for reversible causes. Avoid reflexive IV or PRN therapy. Restart home medications. Prioritize outpatient follow-up. And that wraps up today's episode on inpatient hypertension management. Thanks for listening to Audioboards. Stay tuned for more educational content in our next episode. The views and opinions expressed on the Audioboards podcast do not necessarily reflect those of our employers. This podcast is for educational purposes only and should not be used to diagnose or treat any medical conditions. It is not a substitute for professional medical advice. Always consult a qualified, board-certified healthcare provider for any medical concern.